Hey, so my name is Denise Lee, and I am I did research on training ministry on trauma informed care, suicide awareness, and suicide prevention. And this was for the ECG 692 research class. And so I wanted to talk about that um, and just do a presentation of that. All right, so if I can get this thing going. All right, so according to the World Health Organization, there were more than 700,000 completed suicides each year. And those cases of suicide have actually increased drastically since 2006. Part of the issue for the increase in suicide has been to social isolation, which was mandated by several states when COVID-19, the pandemic, was really in full force. And this also has increased fear over the COVID-19 virus because nobody was for sure, in the beginning, what that was going to look like. And when it came to those in ministry, there was little training on trauma-informed care, suicide awareness, and or even suicide prevention. So it was very much, uh, not knowing what to expect. The other thing with the increase in fear, there was also ex- increased symptoms of mental health problems. They were exacerbated. Sorry, I can't pronounce that real well, which has been made more problematic for those individuals who have experienced financial stress and job loss, social isolation, and a reduction in support services for mental health care um, due to the pandemic. And as I said, for individuals who are involved in ministry, there has been, um, there's hasn't been a whole lot of training on suicide awareness and suicide prevention, as well as trauma informed care. And so for the research, the study was to investigate how effective trauma informed care training is for those individuals. Um, in ministry, if they were taught and trained how to effectively identify trauma, what does trauma-informed care look like, suicide awareness, and suicide prevention. All right, so the impact of COVID-19, obviously, was it increased social isolation because everybody had to be, everybody was made to isolate. And so that has caused an increased anxiety, depression, suicidal behavior, domestic violence, mental health conditions, suicide attempts, sexual assaults, and child abuse. And there was also, as far as suicidality was concerned, there was increased as well, but not to psychiatric symptoms. This was due to more social factors like social isolation, which I just spoke about, those loss of relationships, people who were dying, lack of support, or they were experiencing grief and they were also experiencing shame. And then there was some structural factors in place, that also increased suicidality. And that included job loss, losing a home, not being able to see their providers for support. And and so the other issues also were stress, complicated grief, loneliness, eating disorders, obsessive compulsive disorder, and traumatic stress. So the purpose of this research, started out, I've always had an interest in trauma and trauma-informed care. That's what the area that I specialize in. And over the years, I knew that there had been individuals in ministry that struggled with depression, but it wasn't really being talked about. It was kind of just, uh, you know, not really discussed. Well, in September of 2021, there was a pastor's wife from Georgia. Now, I didn't know this pastor's wife personally, but she had completed suicide, which it had been first reported to myself through a personal text, and then I would see a lot of posts on social media. Um, and the thing about this particular situation was this wasn't the first time that a completed suicide had happened in ministry, but her influence, because she did talk a lot about struggling with suicide and depression, her influence raised the most awareness. And so I began questioning among my colleagues that were within the same religious influence, what could I do? What could we do as a religious body to help those who serve in ministry? And the answer that kept coming up was train ministry about trauma-informed care, what that looks like, suicide awareness and suicide prevention. Because overall, it wasn't being talked about until a tragedy did happen, and then, it quickly was forgotten. I mean, here we are a year later, 2022, November 2022, and I don't really hear a lot anymore, like, about this pastor's wife. So it's a huge concern that needs to be addressed. And so there were two main problems, when it came to you know, that contributed to these issues, why it wasn't being discussed. Well, the first problem is that religious leaders have not been open to having these discussions, particularly about mental health, about psychology, about counseling. And that was found by Hodge et al. In 2020. The other thing is there was a lack of training on trauma-informed care, suicide awareness, and suicide prevention. There really was no excuse for why there wasn't this training. And I'm going to discuss each one of those a little further. So the religious leaders not being open, what had happened, what Hodge found in their Hodge's research back in 2020, that churches and psychology had this tumultuous history, meaning they were operating in separate spheres in opposition towards the work of the other. So there needed to be improvements in attitudes that religious leaders in ministry had towards psychology and counseling. And that started shifting sometime around the end of the 20th century. Until then, there was no little research to show it. The other problem was why there was not an open to discussions was racial and ethical needs weren't being met up until the end of the 20th century. They weren't being recognized and met through counseling. So it obviously wasn't being taken care of. And then the second problem was the lack of training. Because individuals on trauma-informed care, suicide awareness, and suicide prevention. So religious leaders, what happened, especially as we started going into the pandemic, these religious leaders began experiencing an increase in their congregation, members of their congregation, reaching out to them for help. And because of that outreach and because there was a lack of training, well, these religious leaders or individuals in ministry, they were facing personal difficulties. They were experiencing an increase in compassion fatigue and secondary trauma and burnout and even health problems. It was becoming, they were just being impacted and they weren't ready for what the pandemic was bringing. And so the other problematic area was also fear, because religious leaders, ministry was afraid that their church members, their parishioners would be redirected away from what the value of the church stood for. There was also, there was this intellectual humility that was very limiting a person if they had a different viewpoint. Maybe they didn't necessarily agree with the church view. And there was also this lack of emotional intelligence, like not placing importance on areas related to psychology or counseling. Basically, it boiled down to just willful ignorance. um, and so, uh, again, when there was critical situations coming up, um, a lot of it was fear. And I do hear a lot of that from ministry when they're looking for help. They're afraid that counselors are going to uh, project their own personal viewpoint. So there was 3 research questions that I asked. Will the training be effective on educating religious leaders on how to identify individuals at risk for suicidality or those with an unreported trauma history? Will the training be effective in providing support and resources needed in congregations of those in ministry who did participate in the training? And would they be able to develop a mental health team within their church that would also assist other religious leaders? And the third thing was, will the training be effective 2 months post afterwards, in congregations of those in ministry who participated in the training? These were the things that I wanted to know, that I was curious about. And excuse me. So the significance of this research was to provide religious leaders or those in ministry with the additional support and help within their congregations and identify those in ministry who were at risk for suicidality. So the topics that were covered in the training were like appropriate terminology to use, how to identify warning signs, what were the risks of suicide, what were the facts versus the myths, how to identify those protective factors when somebody was contemplating suicide, how to recognize compassion fatigue, how our brain and bodies respond to trauma, how to recognize signs of trauma, appropriate questions to ask. What necessary steps could a person take when someone was experiencing suicidal thoughts, or they had a history of trauma, or they were struggling with compassion fatigue? The other thing was creating a mental health team within their congregations, and then steps to take after a suicide had occurred, had been completed. And the aftercare for those whose family members or church members or maybe a ministry, somebody in a ministry had completed suicide. So those were the various topics that were covered in this training for this research project. So some of the things, the barriers that came up, like, was the stigma within church. The again, and this goes back to, churches weren't talking about it. They weren't having these conversations, and some of those barriers were like, they didn't feel they could discuss suicide within the church. They didn't, they thought it was only for professionals to have those conversations, like counselors or therapists or psychiatrists or psychologists. They felt like a person's faith did not allow for suicidal ideation. They thought if a person was involved in church, they would not have any suicidal thoughts. And they also saw if suicide was talked about, it would be placed in that person's mind, which obviously we know isn't. If somebody's already having those thoughts, it's not because anybody put it in their mind. And religious leaders, they thought that regular attendance would stop suicidal ideation or even suicidality behavior. And the other thing was, God was going to pass judgment because the person was sinful. That was the other thing about the talking about suicide. Excuse me. And so, and in fact, the stigma really went back to St. Augustine back in between 354 to 438 AD. St. Augustine had denounced suicide. And then later in 533 AD, the Catholic Church took a strong stand and declared it unofficial. And so the Catholic Church, by those declarations, it only increased the stigma which surrounded suicide in connection to the church. The other stigma was like mental health. Religious leaders were passing along harsh judgments to those who have experienced mental health issues. I still see that sometimes in today's congregations when I hear messages being preached, and it really is a harsh judgment. The other thing is that lack of knowledge of what mental health is. What does that mean? So some of the impact that has come up for those who are involved in ministry, and this is so very true, and I can speak personally that I've seen some of these very things. My husband is a licensed minister, so I do see some of these things. But the main thing is religious leaders, ministry is dealing with too much compassion fatigue. I see this all the time. And so they're receiving constant criticism from parishioners. They internalize that negative input about, say, somebody in their church stated something about the minister's personal life or their family life, maybe their ministry life, health or faith. Not having a realistic or obtainable goals, sometimes they overstretch themselves, trying to get too much done. Holding the emotional pain of their parishioners, they don't know how to categorize it and, put things in perspective. They want to fix everybody. Not delegating responsibilities. When I did the surveys, when my participants this was one of the main things. They didn't delegate responsibilities to their church staff. And some of that could have been because they didn't have the church staff. Others was because of a lack of trust. Also dealing with internal church conflict or dealing with external stress and even isolation was another one. Also, no support system, within their own religious organization. Having an inadequate level of education or experience, feeling intimidated. There was the financial piece of it, overexposure to negativity on social media, changes in technology. People don't like change, especially when it does come to technology. And then with the pandemic, a lot of church services were not being met in person. And so they were having to do online services. And that was a huge change in technology. Oftentimes ministry felt devalued. They felt worthless. They didn't feel important. They felt pessimistic or they had poor boundaries. And that goes back to not allowing space for people to deal with their own problems, trying to hold that emotional pain for their church members, and then there was stress from overexposure to trauma or death, which we've seen a lot of that during the pandemic. So the training for ministry, it would develop a program to train ministry on how to identify what trauma looks like and suicidality. What would that look like if a person came into their church, never said they had trauma, but what identifiers would be there so that the minister or the ministry team could identify those aspects? It was also to establish a congregation that is trauma informed. That way, when somebody does come visit their church, they would be more aware, more mindful of what was going on. They would also be able to identify parishioners or even fellow ministers in ministry who possibly had a history of trauma. And it wasn't the idea wasn't to just assume everybody had a trauma history. It was just to be proactive in case somebody had a trauma history. The training was also there to provide education to those trusted individuals in their church to help to identify those who were at risk for suicidality or those that were dealing with compassion fatigue. And it was to help religious leaders identify fellow ministers, as I said, that were experiencing compassion fatigue because that was a huge issue. So for trauma-informed care, there was covered the 4 R's, realizing what trauma is, how the brain and body reacts to trauma, recognizing the various types of trauma, knowing the signs of what trauma may appear as, because sometimes what people think is a trauma may actually be, and how to respond appropriately to someone with a history of trauma. And then resist re-traumatization without knowing it, by reducing both those environmental and social cues. That was a big piece of it. And then suicidal awareness, that was one thing that was found, that those religious leaders or ministers who had shown interest in suicidal awareness were more active and empathetic towards those they served. And they also wanted to know how suicide could greatly impact the lives of those they served. So part of that was to identify when a person is experiencing symptoms of compassion fatigue, because compassion fatigue was a forerunner for somebody who would start dealing with suicidal ideation. And also identifying when a person is showing signs of suicidal ideation, suicidal behavior, suicidal tendencies. Now, there is 2 types of suicidal ideation. One is active, one is passive. Obviously, active is when a plan, the means, and intent is all in place. Whereas with passive suicidal ideation, it's not necessarily, it's experiencing those suicidal thoughts, but you don't always have a plan in place or the means or intent. And then the other thing was to have a cognitive state of hopelessness. This is somebody who is showing those signs of suicidality. They were in a constant state of hopelessness, helplessness, worthlessness. Maybe they had fear of death or contemplations around death. And then the other thing the training would provide was suicide prevention. And that was, suicide prevention was teaching ministry how to bear witness to those that were experiencing suicidality. And it was also fostering a care of community, which would start at the local church. Now, that meant creating a mental health team, and these weren't mental health professionals. And it was also considered less formal, meaning than what would be considered of a professional relationship. And these individuals were trained in either psychological first aid or spiritual first aid, because both of those are a huge component when you're dealing with suicidality. And also able to identify those individuals within a congregation who is at risk for compassion fatigue. And then it's just following up with that continued support. That was all part of fostering a caring community. And then also providing support to survivors of a completed suicide, which meant maybe taking them a meal, maybe, helping them out with if they need to get, their financial affairs in order from the individual that had completed suicide in their life. Just those sort of things, and just being an extra support. So the method that was used for this research was to recruit. I've recruited through social media and also the Real Talk 238 podcast, which is a podcast I do. And the focus was to train those who serve in ministry on trauma-informed care, suicide awareness, and suicide prevention. And all the participants, anybody who wanted to participate in the training, they had to be involved in some level of ministry, which could be a pastor, an assistant pastor, maybe an evangelist, a missionary. Maybe this was a district official from their organization they belonged to. And so the requirements to be involved in the training, they had to, of course, complete an informed consent. They completed 5 questionnaires that dealt with different aspects of life, how they believed about mental health, their experience. They had to do a pre-training survey right before the training. Then immediately after the training, they had to do a post-training survey, and they had to do a 2-month follow-up interview. When they completed all that, they got a certificate of completion that they had went through this training. And Zoom was used for the trainings because a lot of these individuals were across the US. There was a few people in Canada. So it was more It was very helpful reaching people. And so the participants, there was 37 who had completed all the requirements to participate in the training, which of course was the informed consent, the questionnaire, the pre and post training. But during the training, one thing that was consistent is they were able to have dialogue. The participants were throughout the training with each other and about the information they were learning. And that allowed participants to share situations and experiences that they were having not only in their church, but also in their ministry and maybe even in their personal life. And so some of the demographics of the participants was 86% were female, 13% were male. The race was 86% Caucasian, 2% African American, 8% was Hispanic, 2% was American Indian. Their education level varied from mostly had a bachelor's degree or some college that was pretty even. And then, of course, the master's degree at 17%. For household income, most of them made between $75,000 to $100,000 annually. Some made over that at 17% was over 100,000 annually. And then most of them were employed at 71%. And then some other things was 77% of them were in their first marriage. They'd never been divorced. 8% were remarried. As far as children in the home, I did ask about children being in the home, and these are ones that are still under 18. Most of them no longer had children in the home. But the ones that did, about 20% had about 2 kids per household. And then I looked at date night, what are they putting into their family life, their personal life? And most of them, about a third of them, didn't really date their spouse too much. The other 23% were persistent with about once a week going on a date night. The other 28%, did about once a month, and everybody else, it just varied. And then for regular vacations, were they practicing self-care? 71% said they did take a regular vacation at least once a year. 24% said they hadn't taken one. And 4% just couldn't afford it. And the other thing I did ask is what was most important to them, from the most important being at the highest level to the least. Well, spouse was number one, their spouse, then their children. Church came in third, their ministry came in fourth. The importance level of themselves was at number 5, and their extended family was as important, and then occupation and school was at the bottom of the list. So I feel like they had a pretty good idea of what a work-life balance was. As far as the training goes, previous training, 42% of the participants had not received any prior training when it came to trauma-informed care, suicide awareness, and suicide prevention. That's that red section of the pie graph. Those who did, 24% of those had received prior training on suicide awareness, 21% had on suicide prevention, and then 13% had received training on trauma-informed care. And so as far as the local church goes, pre-training, I found this very interesting because when it came to trauma-informed care, suicide awareness, and suicide prevention, most of them felt that their local church was somewhat supportive before the training, particularly on suicide awareness and suicide prevention. But as far as trauma-informed care goes, they felt like that most of it was, completely, their local church was completely supportive. And let me just say this first. I asked questions about their local church, the section that the church was located in of the district, and then the district itself, if they're whatever district their church was a part of. And so as far as the post-training, this is immediately after. So if you go back a minute, so as you can see, the trauma-informed care doesn't support and not very supportive. After the training, immediately after, those actually, as far as trauma-informed care, there was some change in that. So there was more, they did feel like their local church was more supportive as in all three areas: trauma-informed care, suicide awareness, suicide prevention. And then at the 2-month follow-up, when I interviewed them at 2 months, they felt like their local church was very supportive, which was very encouraging, I thought, when it came to trauma-informed care, suicide awareness, and suicide prevention. As far as the section goes at the 2-month follow-up, and I did not ask as far as pre and post that, and I wish I had it now, but 2-month follow-up, a lot of the participants were unsure if their section actually supported trauma-informed care, suicide awareness, and suicide prevention, or their section was not supportive, which I thought was kind of disheartening. The district wasn't much better that their church was located in. A lot of them, again, weren't sure, or they didn't feel their district was supportive, or maybe they were somewhat supportive. Whereas like with the local section, the district was a little bit more somewhat supportive than the section. So you can see the difference there. And then as far as the effectiveness of the training, pre-training, some people didn't have any knowledge, some didn't have a lot of knowledge. Most of them had some knowledge of on trauma-informed care, suicide awareness, and suicide prevention. But after the training, this is immediately after, if you notice, everybody had their actual much knowledge was greatly increased compared to pre-training level. So that was huge encouragement, and there was no more reduce the no knowledge to and not much knowledge to nothing. So that was a huge, that was encouraging. And then post-training, as far as was it beneficial, most found it very helpful in both personally, their ministry, and their local church. And then the 2-month follow-up, many of them still said it was very helpful. I think one person, or just a handful, wasn't sure if it was very helpful. So I was encouraged by that. And then as far as the mental health team, that was one of the focuses of this training. 19% said they had started a mental health team. They had one in place. 13% were planning on it, but they hadn't implemented at that point. And 68% said they had not started a mental health team in their church. And so as far as being able to identify someone with a trauma history at the pre-training, 59% weren't sure if they could or could not, whereas 22% said they could, and 19% said they couldn't. After the training, that was a huge improvement. 54% now said, yes, I can identify someone with a trauma history. And 46% of them were still, they weren't sure, maybe they could, maybe they couldn't. As far as PTSD goes, the pre and post training, as you can see, the blue pre-training, a lot of very little knowledge. Post training, they were more competent in their knowledge level of what PTSD looked like, because of course PTSD can also be a precursor to suicidality. And then compassion fatigue versus burnout. Pre-training, a lot of people didn't know the difference. They thought these were the same thing. But after the training, everybody knew that there was a difference between compassion fatigue and burnout. And then pre-training and post-training, as you can see, where compassion fatigue is concerned, pre-training not as knowledgeable, but by the end of the training, they were very knowledgeable. So that was encouraging. And the same thing with burnout. The pre-training, not as knowledgeable, but post-training, very knowledgeable. And then when it came to the 2-month follow-up, were they able to recognize the signs? Most of them were absolutely positive that they could recognize signs of suicide, post-traumatic stress, and compassion fatigue. There are just a few that weren't sure if they could. And as far as recognizing signs of suicide, pre-post training, obviously pre-training, they weren't sure, or maybe they felt kind of in between. Post-training, and this is from least likely to most likely, post-training very much more likely to recognize signs of suicide. And then the belief that asking someone directly that it will cause suicidal thoughts, pre-training, 43% said it could possibly maybe cause those thoughts, but 57% said no. After the training, immediately after, 94% said no. Asking someone directly would not cause a person to have suicidal thoughts. So that was encouraging. And then on taking steps to prevent a suicide, the pre-training, only 16% knew what to do. And I'm guessing that is because they had prior training, and 46% said they thought they kind of knew what to do, but weren't for sure. And then 38% said no, they didn't have an idea. Well, after the training, 76% of the participants knew what to do, those steps to take to prevent a suicide, where 24% said maybe they knew, whereas before it was 46% maybe they knew, and only 16% yes. So there was a great increase there. As far as asking someone directly if they were suicidal, as you can see again with the pre-training in the blue and the post-training in the green, there was a definite increase that they would be likely to ask somebody if they were suicidal. But at the 2-month follow-up, 65% of participants said no, they had not asked anyone. And usually it was because the opportunity hadn't come up. But those that did, the 35% said that it turned out very positive. And then steps to take for survivors of a completed suicide. Would they know what to do if somebody had completed a suicide and there was a survivor of that? Pre-training, they weren't sure, not very knowledgeable. But post-training, they were very knowledgeable, had more competency on what to do. And that's pre-training obviously is blue and post-training was in the green. And so the results of the research, the questions, the training was effective with education and training to identify those individuals in their congregation or ministry who are at risk for suicidality and trauma. There was also, it was effective in teaching ministry, those involved in ministry, how to find resources to help their congregations. And the other thing, the 2-month post, the follow-up, most of those individuals were still thinking proactively about and being more aware and steps to take concerning trauma-informed care and suicidality. So that was encouraging. And then as far as limitations, the sample size was really too small. It would have been better if I had a larger sample size. Also, there was only one religious organization that had participated, and that's just the way it worked out because I did advertise it through social media and my podcast, and I have various people that are from all different religious organizations or denominations. So that was kind of disheartening. The length of the training was really long. Sometimes it would be 4 hours, and a lot of it would depend on how much dialogue was happening between participants. The length of the training really needed to be broken up in maybe smaller chunks of training, like maybe one day just do a training on trauma-informed care, another day do it on the suicide awareness or suicide prevention. And the other thing that was discouraging, a limitation, is that most of the participants had not started a mental health team. The ones that did, that were proactive about it and did, they were very excited what was, that dialogue was happening within their churches. So that was a good thing. And then to decrease the gaps, further research would need to be conducted about training ministry. A larger sample size obviously would need to show that maybe there was a greater impact for those in ministry that had been trained. And also training across multiple religious organizations and denominations, not having it just limited to one particular group. And also, I think it would have been helpful to have a more thorough explanation of what a church mental health team would look like. And I don't think it, I, ex- I don't think I explained that very well through the trainings. So that is, um, that is all of the training I did. I was so excited for the opportunity and appreciative, and it really gave me more of a burden to want to do more for ministry. So, thank you.